debate this morning, and a lot of hands went up actually for people still using this. So I want to go through some basic points. I think there's a lot of confusion, maybe even at times nonsense around this measurement. People get very emotional on it, but I think we could sort of try to come back to earth. So one of the things is that for starters, you can simply measure it without any devices. You're all taught in second-year medical school to identify the sternal angle where the second rib hits the sternum, and that's 5 centimeters above the midpoint of the right atrium, and the distension above that can be used to work out the CVP. So if it's 5 centimeters above and the distension is 8 centimeters, that gives you 13 centimeters of water, and you can convert that into millimeters of mercury by knowing the density of mercury. So you divide by 1.36, not 13.6, because it's centimeters to millimeters, and then you can work out the pressure. And in fact, in my cardiology clinic, that I still keep a small one, and all my patients, I always look at this. It's there, it's easy. Actually, any of the patients in the ICU as well. There's also an echo technique that you can use, that you can put the probe on if you're having trouble seeing it, and there's this reference here for that. So, some technical issues. The critical value for CVP, or right atrial pressure, depends upon where you level the transducer, and this can have a big impact on your measurement. So in my place, we actually use the sternal angle to level our transducers the same way as you were taught in medical school to measure jugular venous distension. However, most places use midaxillary, and on average, there's about close to a 3 millimeter difference between the two, which means if I'm telling you the CVP is 10, if you're using the midaxillary, it's 13 in your unit. So it's important to know that. And Perner's meta-analysis on this, he included data from my study. He didn't allow for the fact that I use a different leveling point. 3 millimeters difference, that's a lot in terms of where you are when the whole gradient is only about 0 to 10 millimeters normally. So this is just illustrating the point. This is looking at a CT scan, and you can see the manometer with the 10 is leveled at the mid-axillary position versus the one with 7 is at the mid-atrial. And if you look at the columns, you can understand this issue of leveling. The one that's 10 at the sternal angle, you can see the amount that it fills up to, where column is going to be more filled than the one that's lower. So leveling is a really, really important point, and you have to be obsessive about picking that spot. Now, it doesn't matter as much which one you pick, as long as you keep it there and track your patients from that point. But to talk to each other, you have to know how you did it. Okay. So this is, I think, where a lot of the problem begins. The first step is, why do you want to know the CVP? What's the purpose? And so in thinking about this talk, there's really 2 reasons in my mind. One is the diagnostic patient assessment, as a starter. And the second one, which we talk about more in these kind of sessions, is monitoring response to therapy. So let me just deal with that first one, diagnostic assessment. Normal CVP is low. And in the supine position, it's probably in a normal person in the range of 0 to 4. In the upright, as you're sitting here, most of you have a central venous pressure which is less than 0. It increases only minimally, even at peak exercise. So here's a venous return cardiac function relationship. Cardiac output was 5 liters a minute, and right atrial pressure is -1. That's normal. The point is, when CVP is elevated, if it's above 4 or 5, that's abnormal. Now, it may not be serious, you may not have to do much, but that is not normal. So in evaluating your patient, that's an important part of the information and understanding how the heart is dealing with the periphery. Just the point about exercise, this was a study we did years ago. On the x-axis is right atrial pressure. We used a PICC line and inserted it to the level of where the superior vena cava hits the right atrium. And we estimated cardiac output for measuring oxygen consumption. And what you see is these normal subjects, young males, sitting on the cycle ergometer at the beginning have a central venous pressure which is below 0. And with exercise, as soon as they start pedaling, it rises somewhat, but then it remains almost constant with cardiac outputs which were close to 30 liters a minute. It just doesn't change. So the point on this is there's little change in CVP with activity. And there's no volume that needed to be added to get to that cardiac output of almost 25 to 30 liters a minute. So your body has huge changes without actually having to add volume. Think of these numbers. So in the intensive care unit, you get really excited when somebody's cardiac output goes from 4.5 to 5 liters a minute. That's nothing compared to what the system can do. And you have to use all that volume to get there. And your system does 5 times that without adding any volume. What does CVP not do? It doesn't stand alone. You cannot take the value out of context. It needs to be considered in the context of the clinical situation. And of course, it doesn't determine blood volume at all, and I won't get into that today. So, an example of context. So a patient presents with dyspnea and shock. The resident considers a pulmonary embolism, and then says to me that the central venous pressure is 0. Well, it's possible, but you got to come up with some pretty creative pathophysiology, like maybe they had a GI bleed or something at the same time. Or take this one, hemorrhagic shock, and the resident tells me the CVP is 20, assuming it's leveled and measured correctly. Well, yes, I agree, it could be, but again, you need some creative pathophysiology. Maybe they had a GI bleed and tamponaded at the same time. But you really got to be creative to explain those two numbers. They might be real, but it should be obvious for some bizarre clinical reason. So I think the major use of CVP is monitoring the response to therapy. So the first step I like to begin with is this. There's a clinical problem that I feel I have to fix at the bedside. So that could be hypotension, it could be low perfusion, it could be low urine output, lactate arising. So now I have a problem, and then the next question is, will the patient actually respond to fluid? So too often I hear the discussion, are they volume responsive or not? If everything's fine, I couldn't care less. They're perfectly fine. It's only when I think I want to use fluids that now I have to ask, is the person responsive? But the first thing is, what's the problem? And that's important because what you want to see is when you gave fluid and you thought that might be the solution, did it fix the problem? So this could be empiric based. In other words, you gave the fluid and you fixed the blood pressure or the urine output or the mental status or any of the respiratory or leg raising tests. But in practice, as I said in the debate we had this morning, you're in the emergency department, the pressure, it comes in, the patient's 70 millimeters of mercury. You're not, and it's shock or septic shock, you're not playing around with making measurements like that. You're giving a bolus of fluid before you move on and see what happens. So it's really important to think about, what does fluid actually do? Like, how does it fix those problems? The low blood pressure, the decreased perfusion, the low urine output. So basically what you're doing is you're using Starlings Law. And to do that, you want to assess the filling pressure of the heart, which is the right atrial pressure, and then you want to somehow measure how that change in filling pressure affected what you're looking at. If you actually measure cardiac output, which we'll hear about soon, and it's really the best way if you can, you want to see the change in cardiac output, not stroke volume. If you don't, you want to see a surrogate. Did the central venous get better? Did the lactate start to fall? Did the patient wake up and start talking to you? All those things. Where the CVP comes in for me, it tells me, did I give enough fluid to test Starling's Law? So I want to know that the CVP rose by, I usually say 2 millimeters of mercury. Why 2? Simply because that's something I think I can recognize on the monitor. That's the only reason. If it's 1, I'm just not sure. You don't have to give a lot of fluid. You can give it rapidly, and 250 mLs given rapidly should easily do this, as I'll show you in the next slide. Notice I wrote right atrial pressure and not pulmonary artery occlusion pressure or wedge. I never use the wedge as a guide to fluid because it's the right atrium where the heart interacts with the return of blood from the periphery. So if I raise the CVP by 2 and the cardiac index goes up, okay, they were responsive. If I haven't fixed my problem, I may continue. But if I raise, let's say I had a patient with a central venous pressure of 3, the way I level, and I increase the CVP to 5, and the cardiac index doesn't change, even though that's a low value, I will not give more fluid because it just showed that they did not respond. They're on the flat part of the cardiac function curve. So So in reality, I think in the real emergency situation, most of our boluses tend to be empiric. You just don't have time to do other stuff. And especially when they come in the emergency department, they may not even have they won't even have an arterial line. They come in, they're pale, they're awful looking, and bang, you go into action. Or the post-op patient who was doing okay and suddenly gets worse. So systolic pressure is 70. You don't need a fancy test. You can just give a small amount initially, and even 500 mLs of a crystalloid is not going to drown anybody if you start with that. So, and most of these patients in reality, I'm sure this is what you do. You don't sit there thinking about it. You give the bolus. You don't have time to play around. Okay. And if fluids is the answer, the response will be fast and in front of you. And one of the things that is I found recently is managing my post-op hearts. And sometimes if the resident's not around, and I'm the one at the bedside and just receive the patient, so they come in, the blood pressure was initially okay and everything looked fine, and then boom, it drops down to like 60, 70, like this, and they drop that fast. You run in the fluids and you just see it in front of you, like the pressure just rises back up. There's no question in your mind that they're being responsive, and because they really need it. So if they really need it, you're not putzing around with other tests. Where you are using those other tests if you're trying to optimize, and I think trying to optimize and finesse is where we get into more trouble, because a lot of times they probably don't need it. So it also helps you whether volume played a role. So if the critically ill patients frequently have a central line in place, so we can actually easily measure it, they're there for catecholamines. And if the cardiac output and tissue perfusion increase, the change in CVP, as I just indicated, gives you an idea of the room for more fluid. So if you still were at a lower level and things improve, well, you know you can probably keep going higher, but you can always keep tracking that by seeing what happens to the cardiac output. But if the clinical condition does not improve, as I said, I stop giving fluids. Now, the big part, as I said, is the response to therapy, as I just indicated. So did the patient respond to fluid? Did the blood pressure go up? Did the perfusion increase? Did the urine output increase? Did lactate decrease? What I want to know is, did the patient respond? I don't want to know whether they're responsive. Just going back to the exercise model, so this is what the typical venous return cardiac function curve, but I've drawn a very large y-axis because this is what actually happens when you exercise. You have to get these kind of numbers, these incredible differences to make these things work. And the point is, the central venous pressure hardly changes for that dramatic change. So fluid is not really a big part of normal physiology. I'm not telling you not to give because you have to in a crisis, but it's really not normal physiology. So a change in volume is not normal physiology normally. Now, even a CVP change of 1 is important. If I just drew a simple cardiac function curve with a plateau at 10 millimeters of mercury, and let's say the cardiac output was 5, and I draw a tangent to that plateau, the slope of that tangent is 500 mLs per minute 500 mLs per millimeter of mercury per minute. In other words, a 1 millimeter change in central venous pressure under this circumstance would cause a 0.5 liter per minute change in cardiac output, and a 2 millimeter change should produce a 1 liter per minute change in cardiac output, and that line is underestimating the steep part of the cardiac function curve. So if the person is truly volume responsive, you should see something happening pretty quickly. It may not stay up, it could quickly leak out, but you should transiently see something, and if you don't, and the CVP rose, then volume is not the answer. And there's a wide variation. This is an old paper of mine, 2007, and what we looked at, these were post-op cardiac surgery patients on day 1 post-op. The clinicians felt the patient needed a bolus of fluid, and then we just looked to see what was the response. So even in the 0 to 5 range, the way I level, you can see that 25% of the patients did not respond. In the 6 to 10, 45 did not respond cumulatively. And by the time we got over 10, at the 11 to 15, 82 had not responded. And in this study, nobody responded over 16. In other studies they have that I've done, but not many. And there's a very important bias in all this literature, because look how few points there are at the 16 to 20, because in my unit, we don't give fluid in that range. The only way I got these numbers, we had one attending who was really big on fluids, and so she actually contributed most of these points, because most of us wouldn't even do it. So there's a strong bias throughout the literature, because this is how all studies are done. And the Perner study, again, he said there was no range that tells you the answers, because people don't give fluids at those higher levels. And if you do, they may raise their cardiac output, but you'll pay a price on the back pressure for the liver and the kidney. Okay, so that's 10 for us. That would be 13 to 15 if you're using Midaxillary. What's really important is the trends. This is where the real answer is. And it's best if you actually mix it with flow. So how do I use the CVP? So trends are most useful. So if you have a fall in CVP, just get my straight with a fall in CVP with a fall in cardiac output, or fall in cardiac output with a fall in CVP, that is a volume process. So the cardiac output fell because of a loss of volume, and the treatment then would be more volume back again. If you have a fall in cardiac output with a rise in right atrial pressure, then that tells you the primary problem was a change in the pump function, and then the answer is treat the pump, dobutamine, epinephrine, milrinone. So that pattern and that relationship gives you a strong clinical indication of what is actually happening in your patient. And then even if you didn't have the cardiac output, if you had the rise in CVP with a blood pressure falling, well, that's going to almost certainly be a decrease in cardiac function. What about if you have no change in CVP, but the cardiac output increased? Well, for that to happen, you actually have to have two things going on. You had to have an increase in the venous return by a volume effect or contraction of your capacitant bed, and an increase in cardiac function, so the net effect is no change. You will commonly see this with norepinephrine and epinephrine. It's really quite common to see that. And even as you take them off, the cardiac output falls, the CVP doesn't change, because you have two things going on. One last one, we can, a few last things. So an old test that I published years ago, and it's still one of my favorite, is you can use the Inspire for breathing spontaneously, or even triggering a ventilator with a spontaneous effort. The fall in right atrial pressure tells you that you're actually on the ascending part of the cardiac function curve, and that you will likely respond to a fluid load. I said likely because you're close to the plateau, and you may not always respond. But if you do not have a respiratory variation, you will not respond. And the test is really more reliable in the negative sense. If you have no variation, it's very unlikely that you'll respond to fluids. And this is essentially the same technique that's used in the test where you're looking at superior vena cava or inferior vena cava with ultrasound techniques. It's the same logic. So it does not work for positive pressure. It's important to know that. It has to be a negative. It could be on a ventilator, but they have to trigger the ventilator. And as I said, the same principle for monitoring SVC or IVC. So two other things to finish up. So this is an example of a hepatojugular reflex. So just pushing on somebody's belly and holding it, you notice here there's a rise in central venous pressure, and if it's staying up for 10 to 20 seconds, that's an indication that the right ventricle is not handling the volume, and a pretty good indication that volume is not going to be helpful. And another very simple one that's just sitting on the monitor, if you're monitoring the central venous pressure, is a prominent Y descent. I've got some numbers from one study I did, but I wouldn't get too hung up on the exact number. But if it's in the range of about a 4 millimeter Y descent, it's a restrictive pattern. It's very unlikely they're going to respond to fluids. It's just sitting up on the monitor. You don't have to do any fancy thing. It's there running in front of you continuously. So the CVP is right in front of you. Learn how to use it. Be a clinician and not just a technician. And just the last thing, this is a paper I wrote in Chest last year, detailed on the title they gave me was right atrial pressure, but CVP, so how to measure it, what's the values, and what are the limitations that goes through all the stuff I just covered. Thank you.